Okay, let's unpack this and jump right into our first one. Let's begin with the condition non-ST segment elevation MI, often called instemmini.
Right, non-ST segment elevation MI. The mechanism here is a subendocardial infarct, basically tissue death that's limited to the inner layer of the heart wall, the subendocardium. This layer is particularly vulnerable to ischemia, to lack of blood flow.
Why is that?
Well, it's the last part of the heart muscle to receive blood. So if blood flow drops, it gets hit first. The heart muscle cells there die from lack of oxygen, but the damage doesn't go through the entire wall thickness.
Okay, and this first story we received really paints a picture of that specific type of heart damage. It's from a patient describing a pretty terrifying night. I woke up in the middle of the night with this terrible squeezing in my chest, like an elephant sitting on me, and it went down my left arm. I've had angina before, but this felt different. It didn't go away with rest or my usual nitro. That was a key difference, the doctor said later, a sign it was accelerating or happening at rest. I also felt nauseous, really short of breath, sweaty. Got to the ER, they did an ECG. Doctor said no ST elevation. That confused me. I thought that was the main heart attack sign. But then the blood test came back. The nurse said my troponin levels were high. That meant heart muscle cells were actually dying, confirming it was a heart attack just in that inner layer. That's what separated it from unstable angina. Apparently those elevated biomarkers, the troponin. Scared, yeah, but also relieved they knew what was happening. They started aspirin, beta blockers right away, prepping for more tests like an echo.
And that's the crucial takeaway for instemming. It is a heart attack, right? But the ECG might not show that dramatic ST elevation. It's those elevated cardiac biomarkers, like troponin, that are the real telltale sign of muscle damage. Confirms that vital inner layer is hit.
Okay, that distinction is clear. Now, let's talk about the one that often triggers that immediate lights and sirens emergency response. ST segment elevation MI.
Right, STEMI. This is generally a more severe form. It's caused by a complete or nearly complete blockage of a coronary artery. And this leads to tissue death, necrosis, that extends through the entire thickness of the heart wall. We call that transmural. So the damage is much more widespread due to a severe prolonged lack of blood flow compared to STEMI.
And this next story really underscores that time is muscle concept when this happens. Never felt anything like it. Crushing weight, center of my chest, so intense I was sweating, couldn't catch my breath. Pain shot up to my jaw, down my left arm, classic radiation. Wife called 911 immediately. In the ambulance, they did an ECG, heard the paramedics say ST elevation. Everything just sped up. Felt like chaos. They told me major heart attack, transmural infarct, entire heart wall. Needed the cath lab now to open the blocked artery. Gave me aspirin, nitro, morphine right there. The urgency was just incredible. They kept talking about door to balloon time because getting that artery open fast at reperfusion is absolutely critical. I think someone mentioned later, because it involved the right side of my heart, they had to be careful with certain meds like nitrates.
Yeah, that avoidance of nitrates or diuretics in right ventricular MI is a key point. But what really stands out with STEMI is that need for immediate action, total blockage, widespread damage, those ST elevations on the ECG. That's the signal. Skip other steps, get straight to opening that artery, usually with PCI, percutaneous coronary intervention. Every single minute counts. Time is muscle.
Okay, shifting now to some potential complications after an MI. Let's look at death within 24 hours post-MI.
Yeah, this is a critical window.
Okay.
In the first 24 hours after a heart attack, the heart muscle is acutely injured. It's electrically very unstable. So the most common cause of death during this very early period isn't the muscle damage itself, but rather life-threatening ventricular arrhythmias. Things like ventricular fibrillation, VF, or pulseless ventricular tachycardia, VT. These chaotic electrical rhythms stop the heart from pumping blood effectively, leads to sudden cardiac arrest. It's fundamentally an electrical problem, right? Not a structural or mechanical one at this stage.
And this next story, it's heartbreaking, comes from a caregiver. It highlights just how sudden and devastating this early complication can be. My dad had his heart attack. We were so relieved when he seemed stable in the ICU. Nurses were checking constantly. But then, just suddenly, the monitors went wild, alarms everywhere. His heart just went into this chaotic rhythm. Ventricular fibrillation, the doctors called it. It stopped pumping blood. It was a life-threatening rhythm starting in the ventricles. He was gone before they could even get the crash cart in properly for CPR and defibrillation. So quick, so unexpected. Like his heart's electrical system just gave out. The doctors explained it was an electrical complication, totally different from the mechanical problems that can happen later. And sadly, the most common cause of sudden death right after an MI.
It's a tragic scenario, and it really underscores the immense electrical instability right after an MI. Even if you restore blood flow, that heart's electrical system is just incredibly fragile. Needs constant monitoring.
Such a stark contrast to that immediate electrical risk is what can happen later. Let's explore death or shock within 3-14 days post-MI.
Right. So now we're in the subacute phase, typically 3 to 14 days after the MI. The dead heart tissue is starting the healing process, but that also involves breaking down. Macrophages, those are immune cells, come in to clear away the dead cells. But this cleanup process actually weakens the heart wall structurally, makes it vulnerable to mechanical complications. Things like rupture.
Rupture of the heart wall itself.
Yes, or parts within it. You can get rupture of a papillary muscle. It usually happens around day 2 to 7. Or the interventricular septum, the wall between the ventricles, around day 3 to 5. Or even the left ventricular free wall itself, typically day 5 to 14. Any of these ruptures cause severe hemodynamic compromise, basically. The circulation collapses, leads to shock or death. These are mechanical failures.
Wow. Another difficult story here, this one from a grandchild, really showcases these later mechanical complications. My grandmother was recovering well after her heart attack. We thought, the worst was over. But about a week later, smack in that vulnerable 5 to 14-day window the doctors mentioned where the tissue is breaking down, she suddenly got really short of breath. Doctors rushed in, said she had a new, loud pansystolic murmur when they listened to her heart. They explained part of her heart muscle, weakened by the MI, had actually torn, specifically a papillary muscle. This caused her mitral valve to leak severely, filling her lungs with fluid, pulmonary edema. They stressed it was a mechanical complication from the tissue degradation during healing, not electrical like the early risks. Just terrifying. A reminder that even after the initial crisis, the heart is still fragile, prone to these structural failures, and they mentioned similar things can happen with the septum or the free wall, often needing emergency surgery if caught in time.
Exactly. The key here is the timing and the nature of the complication. After that initial electrical instability phase, the heart enters this healing phase where the dead tissue breakdown makes it mechanically fragile, leads to these critical ruptures, often signaled by things like new heart murmur or sudden worsening, clearly different from the very early electrical issues.
Okay, moving to another electrical issue, but a different kind. Let's discuss Wolff-Parkinson-White, or WPW.
WPW. This one's fascinating, electrically speaking. It's caused by an abnormal accessory electrical pathway, sometimes called the bundle of Kent. This extra wire basically connects the atria directly to the ventricles, completely bypassing the normal AV node pathway.
So it's like an electrical shortcut.
Precisely. And this shortcut causes the ventricles to start depolarizing or firing prematurely. On an ECG, this shows up as a characteristic delta wave, looks like a slurring upstroke on the QRS complex. This extra pathway can also set up a rapid looping reentrance circuit that leads to episodes of supraventricular tachycardia, SVT, really fast heart rates.
And we have a submission here from a patient describing what sounds like a really frustrating and frightening journey to getting diagnosed with WPW. Every now and then, usually when I was just sitting quietly, my heart would just take off, racing like crazy, felt like it would burst out of my chest. So fast I'd get lightheaded, out of breath. One time I actually blacked out for a few seconds. Scary stuff. Doctors kept saying SVT. But the regular meds like beta blockers or calcium channel blockers, they didn't seem to help. Sometimes felt like they made it worse. Finally, an ECG caught it this weird delta wave that slurred upstroke. That plus a short PR interval and a widened QRS. They told me I had Wolff-Parkinson-White syndrome. This extra electrical connection was bypassing the normal route, causing the symptoms, and it explained why those other meds, the ones that block the AV node, were actually contraindicated. They could force the signals down the fast accessory path, making the rhythm even faster, potentially dangerous. They said procainamide was better for acute episodes, and that something called radiofrequency catheter ablation could potentially cure it by zapping that extra pathway.
Yeah, what makes WPW unique is that abnormal bypass pathway. It's not just that the heart beats fast, but how it gets fast is different. And crucially, as the story highlights, some common heart meds can be dangerous because of that electrical shortcut. That delta wave on the ECG, along with the short PR and wide QRS, that triad is the diagnostic key.
Okay, now shifting to a genetic heart condition, hypertrophic obstructive cardiomyopathy, HOCM.
Right, HOCM. This is a genetic condition, usually caused by mutations in genes for sarcomeric proteins, things like myosin-binding protein C and beta-myosin heavy chain. These are proteins in the heart muscle itself. These mutations lead to abnormal concentric thickening of the heart muscle, especially the interventricular septum, that wall between the lower chambers. This muscle gets too thick, it gets stiff, and that creates an obstruction to blood flow leaving the heart. It also makes the heart prone to dangerous, life-threatening arrhythmias, which is why HOCM is a common cause of sudden cardiac death, especially in young people.
And This next story, it's just devastating from a parent. It really illustrates this hidden danger in young, seemingly healthy individuals. My son was a star basketball player, incredibly fit, healthy, looked perfect. One day during practice, he just collapsed on the court. No warning at all. Doctors later told us he had hypertrophic cardiomyopathy, a genetic thing, mutations in his heart muscle proteins. His heart muscle was too thick, especially the septum. It created a blockage for blood flow, and also this environment prone to dangerous rhythm problems. They said it put him at high risk for a fatal arrhythmia. Tragically, it's the most common cause of sudden cardiac death in young athletes. Just devastating because he looked fine. But his heart had this hidden structural problem that took him from us so suddenly. They did mention for others, treatments like beta blockers can help symptoms. And sometimes an implantable defibrillator, an ICD, can prevent death from arrhythmia.
Yeah, the silent and often tragic nature of HOCM, particularly in young athletes, is what makes awareness so important. That underlying genetic defect leads to a physical abnormality, the thickened muscle, that not only obstructs blood flow, but creates this dangerous electrical instability, often with no outward signs until a catastrophic event.
Let's drill down a bit more on HOCM symptoms. Let's talk about syncope and dyspnea in HOCM.
Okay, so building on HOCM, the syncope, which is fainting, and the dyspnea, shortness of breath, these are direct results of that unique mechanical problem. You have the thickened septum, right?
Yeah.
Plus something called systolic anterior motion, SAM, of the mitral valve. Basically, during each heartbeat, systole, the mitral valve leaflet gets pulled towards the thickened septum.
It gets sucked in.
Exactly. Gets sucked into the outflow tract.
Yeah.
And this physically obstructs blood flow leaving the left ventricle. It's like the exit door gets squeezed shut partially. When you exert yourself, your heart beats harder and faster, which actually worsens this obstruction. So less blood gets to the brain, causing syncope or lightheadedness, and blood backs up into the lungs, causing dyspnea.
And this next listener story really shows how that mechanism plays out in everyday life. I used to love hiking, but lately, just walking up a steep hill, I get so winded I have to stop. A couple of times, I even felt so dizzy I almost passed out. Terrifying. Feeling like I can't get enough air, then my vision tunnels. My doctor explained my heart muscle is too thick, especially the septum. And the way my mitral valve moves, that SAM thing, when I exert myself, it's like the exit door for blood gets squeezed shut. Outflow obstruction. That reduced blood flow to my brain causes the dizziness, the near fainting, and the backup into my lungs makes me breathless. The doctors kept pointing out how my heart murmur gets louder when I stand up or do a Valsalva maneuver like bearing down, because those actions decrease the amount of blood returning to the heart, decrease preload, and that actually worsens the obstruction. That was a key physical exam finding, they said, directly linked to the mechanism. They put me on beta blockers to slow my heart rate, let it feel better, and told me to avoid anything that dehydrates me or reduces preload.
That's a perfect illustration. It shows how the physical obstruction in HOCM gets worse with exertion or maneuvers that decrease preload. Understanding how those preload changes affect the murmur, that's a powerful diagnostic clue that directly reveals the mechanical problem at play.
Okay, let's shift gears now to a really critical set of conditions, shock syndromes, starting with hypovolemic shock.
Right, hypovolemic shock. This basically means there's a significant reduction in the body's circulating blood or fluid volume. Think of your heart as a pump and blood vessels as pipes. In hypovolemic shock, there just isn't enough fluid in the pipes.
Okay, low volume.
Exactly. Low volume. So less blood returns to the heart that's decreased preload. With less blood coming in, the heart can't pump as much out. Cardiac output drops dramatically. And the result is that tissues throughout the body don't get enough oxygen.
This story from a trauma patient sounds like a classic example of how the body reacts to severe fluid loss. Terrible car accident. When the paramedics got there, I felt incredibly weak, dizzy. They said my heart was racing tachycardia, often the first vital sign to change, they told me. My blood pressure was dangerously low, hypotension. But apparently that only falls after you've lost quite a bit of volume. I felt cold and clammy all over, even though it wasn't cold outside. Classic sign, they said. My body was trying to shunt blood to vital organs by clamping down peripheral vessels. Remember them rushing me to the hospital. Said I had lost a lot of blood, decreased preload, decreased cardiac output, needed fluids immediately. Started an IV, just pumping in isotonic solutions, saline, then blood transfusions. Slowly started to feel a bit more alert. The main problem, just not enough fluid volume in the system.
Yeah, the body's immediate response is compensation. Speed up the heart rate, clamp down blood vessels. That cold, clammy skin is a direct result, shunting blood away from the periphery. And the treatment is intuitive. Aggressive fluid resuscitation. You're literally replacing what's missing to fill the tank back up.
Okay, so that's low volume shock. Our next condition is cardiogenic shock. Sounds like a different kind of pump problem.
Exactly. In contrast to hypovolemic, where there's not enough fluid. Cardiogenic shock is when the heart itself fails as a pump. It's a severe impairment of the heart's pumping function, usually due to left heart dysfunction, like after a massive heart attack. This directly significantly reduces cardiac output. The pump is broken. And because the pump is failing, blood backs up. So you get inadequate blood flow to the body, plus fluid congestion backing up into the lungs and the venous system.
And this story comes from a spouse, illustrating just how profound the impact is when the heart simply can't pump effectively. My husband had a massive heart attack. Even after they opened his artery in the cath lab, he was still very, very sick. He developed cardiogenic shock, blood pressure dangerously low, skin cold, clammy, poor perfusion, but he was also struggling to breathe. His lungs were filling with fluid. You could hear crackles, pulmonary rales everywhere. His neck veins, the jugulars were distended. Doctors pointed out a new S3 heart sound, a sign of that fluid overload. They explained his heart muscle was so damaged, maybe over 40% of his left ventricle, it just couldn't pump enough blood. Cardiac output severely reduced. But unlike hypovolemic shock, his pulmonary capillary wedge pressure, a measure of lung congestion, was elevated because of all that fluid backing up. They had him on inotropes to help his heart squeeze harder, vasopressors to keep his pressure up, even talked about a balloon pump to help circulation, all while treating the underlying MI.
Right. What defines cardiogenic shock is that pump failure. You see signs of both poor circulation and fluid backup. That combination, cold, clammy skin with pulmonary edema, JVD, maybe an S3, that's the classic picture, screaming pump failure, need to support the heart and treat the cause.
Okay, finally in this segment, let's explore distributive shock. Here, the issue seems to lie more with the vessels themselves.
That's right. Distributive shock isn't primarily about the pump or the volume. It's about the pipes, specifically widespread severe vasodilation. The blood vessels become far too wide and leaky. This dramatically decreases systemic vascular resistance, or SVR, the resistance the heart pumps against. When SVR plummets, there isn't enough pressure to push blood effectively around the body or even get it back to the heart properly. Leads to inadequate tissue perfusion. Sepsis, that overwhelming response to infection, is the most common cause.
And this next story comes from a grandchild, showcasing this type where the vessels are the main problem. My grandmother was recovering from pneumonia, then suddenly got much worse. Blood pressure plummeted, barely responsive, but her skin felt oddly warm and dry. That seems strange for shock. Doctors explained the infection caused her blood vessels to dilate widely all over her body, so much that her SVR dropped too low to perfuse her organs. Even though her heart was actually pumping harder initially, trying to compensate her cardiac output might have even been high early on. They called it septic shock, the most common type of distributive shock. Immediately started broad-spectrum antibiotics, plus a 5V fluids and vasopressors like norepinephrine to clamp down those vessels and bring her pressure back up by increasing SVR. Just a race against time to support her circulation while fighting the underlying infection.
Yeah, that warm, flushed skin, especially early in septic shock, despite critically low blood pressure, that's a striking feature. It's a direct result of that massive vasodilation. A stark contrast to the cold, clammy skin you see in hypovolemic or cardiogenic shock. It's fundamentally a problem of vessel tone, not necessarily pump function or fluid volume initially.
Okay, let's move on to our next segment, autoimmune and hormonal conditions, starting with rheumatic fever.
Rheumatic fever. This is a serious but importantly delayed complication of an untreated base strep throat infection. Pharyngitis specifically, not skin infections. It's an autoimmune condition. What happens is something called molecular mimicry. Basically, your immune system makes antibodies to fight the strep bacteria's M protein. Fine so far. But these antibodies mistakenly cross-react with similar-looking self-antigens in your own body tissues.
Attacks itself.
Exactly. Particularly in the heart, joints, brain, and skin. This triggers what's called a type 2 hypersensitivity reaction, causing inflammation and tissue damage.
And this submission from a worried parent really highlights why treating even a simple sore throat is so important. My daughter had a sore throat a few weeks back. Didn't think much of it. Then she started complaining about her joints. First her knees, then ankles, then wrists swelling up, hurting terribly, and it moved around. Migratory polyarthritis, they called it. She also had a fever, seemed really tired. Doctor did blood tests, found high antibodies against strep and elevated ASO titer, even though her throat felt fine by then. Diagnosis: rheumatic fever. Explained her immune system made antibodies against the strep M protein, but now those antibodies were mistakenly attacking her own tissues, type 2 hypersensitivity. They were really worried about her heart, the most serious part. Often affects the mitral valve long term. Her ECG even showed a prolonged PR interval, had to start strong anti-inflammatories, and now needs long-term penicillin for years to prevent it coming back and causing more heart valve damage, all because of that initial strep throat.
Yeah, the key points there. Delayed onset after strep throat, that characteristic migratory joint pain, but the real danger is the carditis, the heart involvement. Can lead to permanent valve damage, most commonly mitral stenosis down the line, which is why prompt treatment of strep pharyngitis is crucial for prevention.
Okay, our next condition involves genetics and hormones, the most common form of congenital adrenal hyperplasia.
Right, the most common form of CAH. This is due to a deficiency in an enzyme called 21-hydroxylase. This enzyme is absolutely critical for making two key hormones in the adrenal glands: cortisol, the stress hormone, and aldosterone, which regulates salt and water balance. When 21-hydroxylase is deficient, the body just can't produce enough cortisol and aldosterone. The pituitary gland senses the low cortisol and ramps up production of ACTH, trying to stimulate the adrenals. But because of the enzyme block, the precursors can't go down the cortisol-aldosterone path. Instead, they get shunted over into the androgen pathway. Result: excess sex hormones, particularly androgens.
And this moving story from new parents really highlights how critical this diagnosis can be, often right after birth. Our baby girl was born, we were thrilled. But the doctors noticed something unusual about her genitals. Seemed a bit ambiguous. Within a few weeks, she started vomiting constantly, became lethargic. Her blood pressure dropped dramatically. Terrifying. We learned she was in a life-threatening salt-wasting crisis. Labs showed low sodium, hyponatremia, and high potassium, hyperkalemia. They did a specific blood test, found a very high level of something called 17-hydroxyprogesterone. Doctors explained. Genetic condition, congenital adrenal hyperplasia, due to 21-hydroxylase deficiency. About 90% of CAH cases are this type. Her body couldn't make enough cortisol and aldosterone, instead made too many male hormones, causing the ambiguous genitalia in females and that dangerous salt-wasting crisis. Now she's on lifelong hormone replacement. Takes glucocorticoids and mineralocorticoids every day. So grateful they figured it out.
It's a powerful story. Highlights the two major presentations of this classic form: ambiguous genitalia in female newborns, and that life-threatening salt-wasting crisis with electrolyte chaos, and that markedly elevated 17-hydroxyprogesterone. That's the key diagnostic biochemical marker for the specific, most common type of CAH.
Now, for a condition that feels like the body's thermostat is broken and the engine is running way too fast, heat intolerance and weight loss in hyperthyroidism.
Exactly. Hyperthyroidism is when the thyroid gland goes into overdrive, producing too much thyroid hormone T3 and T4. These hormones crank up your basal metabolic rate, speed up pretty much all your body's processes. This increased metabolism generates excess heat, leading to that classic heat intolerance. And it accelerates calorie burning, causing weight loss despite often having an increased appetite. You're burning fuel like crazy. Plus, excess thyroid hormones increase sensitivity to catecholamines, like adrenaline, explaining symptoms like anxiety and rapid heartbeat.
And this next listener describes exactly that feeling, like their body was just stuck in overdrive. Couldn't stop losing weight, even though I was eating more than ever. Clothes were just hanging off me, and I was always, always hot. Used to love summer, now I felt like I was melting even in AC. That heat intolerance was intense. Came from my body's increased metabolic rate, they said. Heart pounding constantly. Felt jumpy, anxious all the time. Skin felt warm, moist. Hair seemed finer. Doctors suspected my thyroid. Blood tests confirmed it. Low TSH, high T4 and T3, hyperthyroidism. Felt like my body was just stuck in high gear, burning calories way too fast, making me super sensitive to adrenaline effects. Started me on beta blockers for the pounding heart and anxiety, and antithyroid drugs like methimazole to lower the hormone production.
Yeah, the core of hyperthyroidism is that revved-up metabolism. Weight loss despite increased appetite, profound heat intolerance, direct consequences of the body working overtime, burning calories, generating heat, a systemic acceleration.
Okay, now for the flip side. A stark contrast. Myxedema in hypothyroidism.
Right. In severe hypothyroidism, an underactive thyroid, low T3, T4, the body's metabolism slows way down. This slowdown leads to an accumulation of specific water-tracking substances. We call them hydrophilic glycosaminoglycans, like hyaluronic acid. These substances build up in the interstitial spaces, the areas between cells. They bind water, causing a very characteristic type of swelling called non-pitting edema.
Non-pitting? How's that different?
Unlike typical swelling where pressing a finger leaves a dent, this edema feels kind of doughy or waxy. It doesn't pit when you press it. That's a myxedema.
And this listener describes feeling their body slow down dramatically. Just so tired all the time, no matter how much I slept. Lethargic. Gained weight despite not eating much. Always cold, even when others were warm. Cold intolerance. Skin felt dry, thick, coarse. Noticed my face getting puffy, especially around my eyes. Voice seemed deeper, and the swelling in my legs, when I pressed it, no dent. Distinctly non-pitting edema, doctor explained. Underactive thyroid, low free T4, high TSH, this puffiness was myxedema. Buildup of those water-attracting things like hyaluronic acid in my tissues because my metabolism had slowed so much. Now I take levothyroxine, synthetic thyroid hormone, every day. So glad they caught it before it became a myxedema coma, a real emergency.
Myxedema is really the hallmark physical sign of severe, long-standing hypothyroidism. And that non-pitting nature of the edema is the key distinguishing feature. Directly reflects that unique biochemical buildup, pulling fluid into tissues differently than simple fluid overload does.
Okay, next up, an interesting autoimmune twist affecting the eyes. Graves' ophthalmopathy.
Yes, Graves' ophthalmopathy. Strongly associated with Graves' disease, most common cause of hyperthyroidism. In Graves's, the immune system makes antibodies called thyroid-stimulating immunoglobulins, or TSIs. They usually attack the thyroid gland. But in Graves' ophthalmopathy, these same TSI antibodies cross-react with receptors on fibroblasts, cells located behind the eyes, in the orbit. This activation causes these retroorbital fibroblasts to proliferate, to multiply. And they produce excessive amounts of those hydrophilic glycosaminoglycans we just talked about with myxedema. This accumulation of cells and gags increases the volume within the bony eye socket, pushes the eyeballs forward, that's exophthalmos, or bulging eyes. It also affects the eye muscles, causing inflammation and swelling, which can lead to double vision or diplopia.
And this next story really shows how an autoimmune condition can have these surprising effects, seemingly separate from the main organ involved. My eyes started to bulge out. Wasn't my imagination. People noticed. They felt gritty, painful. Sometimes I'd see double, especially looking side to side, classic diplopia. So embarrassing, felt like everyone stared. I already had the Graves' disease diagnosis, knew about the TSI antibodies. My thyroid levels were actually under control with medication. But my eyes just kept getting worse. Eye doctor said it's the same immune problem attacking my thyroid, but this time attacking the fibroblasts and tissues behind my eyes, causing them to swell, push forward. She also really emphasized that smoking would make it significantly worse, and that the eye problem severity doesn't always track with the thyroid hormone levels. Started on glucocorticoids to reduce inflammation, use artificial tears constantly. It's a battle.
Yeah, what's striking about Graves' ophthalmopathy is that it can run its own course, independent of the thyroid hormone levels. You could be euthyroid, have normal levels, and still have progressive eye symptoms because it's a distinct autoimmune attack on those orbital tissues. The exophthalmos and diplopia are direct results of that increased volume and inflammation behind the eye.
Okay, let's consider primary hyperparathyroidism. Sounds like something often found by accident.
Often, yes. Primary hyperparathyroidism is usually caused by an overactive parathyroid gland. Most commonly, it's a benign tumor, a parathyroid adenoma, on one of the four glands. Sometimes it's hyperplasia, where the glands are just enlarged and overactive. These glands produce parathyroid hormone, PTH, which is central to calcium regulation. In primary hyperparathyroidism, you have too much PTH being produced autonomously. Excess PTH leads to high blood calcium levels, hypercalcemia. It does this by telling the kidneys to reabsorb more calcium, telling the bones to release calcium, and activating vitamin D, which then increases calcium absorption from the gut.
And this next story really backs up that found by accident idea, but shows how symptoms can be subtle. Surprised when my doctor said my calcium was high on a routine blood test. Didn't feel particularly sick, but looking back, yeah, I'd been feeling pretty tired, a bit down, maybe irritable for a while. And I had a kidney stone last year. They now call that a stone from the mnemonic bones, stones, abdominal groans, and psychiatric overtones. Helps remember the symptoms. Doctor explained one of my tiny parathyroid glands had a little tumor, an adenoma, making too much PTH. Said that's why my bones were a bit thin on scan osteopenia, part of the bones, and why I got that kidney stone. My PTH level was high despite my calcium already being high. That confirmed it was a primary problem with the gland itself. The solution: surgery to remove that single overactive gland. Definitive treatment.
Exactly. Primary hyperparathyroidism is a condition of inappropriately high PTH leading to high calcium. That bones, stones, abdominal groans, psychiatric overtones, mnemonic is incredibly useful for remembering the widespread effects of chronic hypercalcemia, driven by that overactive gland, usually just one adenoma.
Okay, so in contrast to primary, let's explore secondary hyperparathyroidism.
Right. Secondary hyperparathyroidism is fundamentally different. It's a compensatory response. It's not a problem with the parathyroid glands themselves initially. It happens because of prolonged low calcium levels and high phosphate levels in the blood. The most common cause by far is chronic kidney disease, CKD.
How does kidney disease cause it?
Well, damaged kidneys can't properly excrete phosphate, so phosphate levels rise. They also can't activate vitamin D effectively. Active vitamin D is needed to absorb calcium from the gut, so calcium levels tend to fall. This combination, low calcium, high phosphate, strongly stimulates all four parathyroid glands. They enlarge hyperplasia and pump out lots of PTH in an attempt to raise calcium and lower phosphate. So you end up with high PTH levels, but typically with low or maybe normal calcium levels.
And this clinician's story really highlights that complex interplay between organs and chronic disease. I've been on dialysis for years, failing kidneys. Lately, had this deep, aching pain in my bones, a sign of renal osteodystrophy, they call it. Feel so weak too, doctors explained. Because my kidneys don't work, they can't get rid of phosphate or activate vitamin D right. Leads to low calcium, high phosphorus. To compensate, all four of my parathyroid glands have been working overtime, became hyperplastic, making tons of PTH trying to fix the calcium phosphorus problem. They call it secondary hyperparathyroidism. Labs showed high PTH, sure, but my calcium was actually low normal. That's the key difference from primary. Now I take phosphate binders with meals to lower phosphorus and active vitamin D calcitriol to help calcium and suppress PTH. Trying to protect my bones, it's a compensatory disorder, not a primary gland problem.
That's the critical distinction. Secondary hyperparathyroidism is a response to another problem, usually kidney failure. Leads to high PTH, but calcium is low or normal. It's the body's ultimately harmful attempt to fix a systemic imbalance caused by the failing kidneys, whereas primary is the gland itself being the source of excess PTH.
Okay, let's look at another electrolyte issue. Euvolemic hyponatremia in SIADH. Sounds complex.
It can be puzzling. SIADH stands for Syndrome of Inappropriate Antidiuretic Hormone Secretion. ADH, or vasopressin, is the hormone that tells your kidneys to hold on to water. In SIADH, there's excessive unregulated secretion of ADH. It's being released when it shouldn't be. So the kidneys hold on to too much free water. This dilutes the blood, resulting in low sodium levels hyponatremia. But here's the weird part. Despite holding on to extra water, the patient often looks euvolemic, meaning they don't have signs of fluid overload like swelling or edema, and they aren't dehydrated either.
How can they hold water but not look swollen?
It's thought that the initial slight increase in volume suppresses the renin-angiotensin-aldosterone system and stimulates natriuretic peptides. These hormones then cause the kidneys to excrete sodium. So you end up with this situation. Too much water retained, diluting the blood sodium, but also actively losing sodium in the urine, which helps keep the overall volume status looking relatively normal. It's hyponatremia in a euvolemic patient.
And this next story from a caregiver illustrates that puzzling picture confusion, low sodium, but no obvious fluid issues. My dad had been acting a little confused, talking slowly, more tired than usual. Subtle changes. He didn't look swollen, wasn't dehydrated, looked normal volume-wise. Euvolemic, that was a key clue the doctors kept saying. Blood tests came back. Sodium was very low, hyponatremia. Blood was too dilute. They also checked his urine. And despite the low blood sodium, his urine was paradoxically concentrated with a high urine osmolality and high urine sodium. Shouldn't be happening. Diagnosed him with SIADH. Explained his body was holding on to too much water due to excessive ADH. They suspected it might be related to his recent small cell lung cancer diagnosis, apparently a classic cause of SIADH. The tumor itself can make ADH. That excess water dropped his serum sodium, and even though his body tried to compensate by peeing out sodium, it was still holding too much water overall. Treatment. First line was drastic fluid restriction. Had to cut back his water intake significantly to let the sodium level come back up. Critical to prevent seizures or worse.
Exactly. The mystery of SIADH is that euvolemic appearance despite the low sodium. That combination, hypotonic hyponatremia, euvolemic status, and inappropriately concentrated urine with high urine sodium. That's the diagnostic fingerprint. As the story highlighted, looking for underlying causes like small cell lung cancer, CNS disorders, or certain drugs is crucial. Fluid restriction is key management.
All right, let's move into diabetes complications, starting with small and large vessel disease in diabetes mellitus.
Okay. Chronically high blood glucose levels in diabetes cause damage to blood vessel walls through a process called non-enzymatic glycation. Essentially, excess sugar molecules randomly bind to proteins in the vessel walls. This glycation makes the proteins abnormal, causing vessel walls to stiffen, thicken, and generally dysfunction.
And this happens in all blood vessels.
It happens everywhere, but the manifestation differs depending on the vessel size. In small vessels, the microvasculature, like capillaries and arterioles, it causes something called hyaline arteriosclerosis, basically thickening and hardening of these tiny vessels, particularly in the kidneys and eyes. In large vessels, the macrovasculature, like the coronary arteries, carotid arteries, arteries in the legs, it dramatically accelerates atherosclerosis, the buildup of fatty plaques. Both processes ultimately compromise blood flow, but lead to different clinical problems.
And this next story comes from a long-term diabetes patient, really describing the pervasive nature of these complications. Had diabetes for 20 years now, it's taking its toll. First thing I noticed, vision getting blurry. Eye doctor said diabetic retinopathy. Damage to the tiny vessels in the retina, microvascular complication. Then my feet started feeling numb, tingling. Developed an ulcer on my toe that just wouldn't heal. That's peripheral neuropathy plus poor circulation from peripheral arterial disease, PAD. Nerve damage is micro, PAD is macrovascular. And just last month, had a silent heart attack. Doesn't even feel classic chest pain. Another macrovascular issue, coronary artery disease. Doctors said the diabetes just made my large arteries harden much faster than they should have. Accelerated atherosclerosis. Feels like this disease is damaging all my body's plumbing. From the smallest capillaries via hyaline arterial sclerosis to the biggest arteries via that non-enzymatic glycation, doctors keep stressing strict blood sugar control helps slow down the microvascular stuff. But for the macrovascular, it's that, plus aggressive control of all risk factors, blood pressure, cholesterol, stopping smoking, maybe aspirin.
Yeah, that pervasive damage to both micro and macrovasculature is what makes diabetes so challenging systemically. Retinopathy, nephropathy, kidney disease, neuropathy, nerve damage, classic microvascular triad, coronary artery disease, peripheral artery disease, stroke, the big macrovascular threats. The story really captures how this sugar damage impacts nearly every organ system through vessel disease. Tight glucose control is key, especially for microvascular, but broader risk factor management is vital for macrovascular outcomes.
Okay, next, a very serious acute complication of diabetes, diabetic ketoacidosis, DKA.
Right. DKA typically occurs when there's an absolute or near absolute deficiency of insulin. Most common in type 1 diabetes, but can happen in type 2 under stress. Without enough insulin, your cells can't take up glucose from the blood for energy, so blood sugar skyrockets, hyperglycemia. The body, thinking it's starving despite the high blood sugar, switches to burning fat for fuel. It breaks down triglycerides into free fatty acids. The liver then takes these fatty acids and converts them into ketone bodies like acetoacetate and beta-hydroxybutyrate through ketogenesis. These ketone bodies are acidic. As they build up, they overwhelm the body's buffering systems, making the blood dangerously acidic. There's a high end-in-gap metabolic acidosis part of DKA.
And this submission is from a college student. It shows just how quickly DKA can escalate, especially in type 1. College student, type 1 diabetes, felt really sick for a couple days, nausea, vomiting, this awful stomach pain, figured it was just a stomach bug, barely ate, skipped some insulin doses, big mistake, then started breathing really hard and fast, almost panting. My roommate noticed that it looked like small respirations. Later learned that's the body trying to blow off CO2 to counteract the acid. My breath smelled weird too, fruity like nail polish remover. That's the acetone, one of the ketones. By the time I got to the ER, I was barely conscious. Altered mental status, they told me. Diabetic ketoacidosis, not enough insulin, body making too much acid from burning fat, blood glucose, over 250, blood pH, low, acidic, ketones, high in blood and urine. That's the diagnostic triad, hyperglycemia, acidosis, ketones. Treatment was immediate, lots of IV fluids first to rehydrate me, then an IV insulin drip, plus potassium replacement because insulin drives potassium into cells and my total body potassium was low. A true medical emergency.
That story hits all the key features. The hyperglycemia, the high end-in-gap metabolic acidosis with ketones, those characteristic Kussmaul breaths and fruity odor. It's a complete metabolic breakdown. The body is forced into dangerously burning fat. And importantly, treatment starts with aggressive fluids before focusing solely on insulin. Need to restore volume and perfusion first.
Okay, our final diabetes complication today, often seen in older adults with type 2, hyperosmolar hyperglycemic state, or HHS.
Right, HHS. This typically affects older adults with type 2 diabetes, often triggered by an underlying illness or infection that leads to dehydration. The key difference from DKA is that in HHS, there's usually just enough insulin present to prevent widespread ketogenesis, so you don't get the significant acidosis or high ketone levels seen in DKA. However, there isn't enough insulin to prevent severe hyperglycemia. Blood sugars can get incredibly high, often over 600, sometimes over 1,000. This extreme glucose level acts as a powerful osmotic diuretic. It pulls huge amounts of water out of the body's cells and into the urine. This leads to profound dehydration and a dangerously high serum osmolality. The blood becomes extremely concentrated or hyperosmolar.
And this next account from a child describing their elderly father's symptoms led to this urgent diagnosis. My elderly dad has type 2 diabetes, hadn't been feeling well for a week, bad cough, wasn't eating or drinking much. Then he became extremely confused, disoriented, almost unresponsive. His skin felt very dry, poor turgor. Checked his blood sugar unbelievably high, over 800. Doctor said his blood was incredibly thick, hyperosmolar. Serum osmolality was way up, over 320. But, and this was the key difference they stressed, unlike DKA, he didn't have significant ketones in his urine or blood, often the case in type 2DM with HHS. They explained his body was severely dehydrated. That extreme sugar level was pulling all the water out of his cells via osmotic diuresis, causing the neurological changes. Treatment started immediately with massive amounts of IV fluids. That was the absolute priority, rehydration. Then some insulin, given slowly and carefully to bring the sugar down gradually once fluids were going.
Exactly. HHS is fundamentally a crisis of extreme hyperglycemia and profound dehydration, leading to hyperosmolality. The lack of significant ketones, the often much higher glucose levels than DKA, and the pronounced neurological changes, typically in older adults with type 2 diabetes, those are the key differentiating features. And the cornerstone of initial management is aggressive IV fluid resuscitation to correct that severe dehydration.
All right, let's delve into our final segment, some GI tract oddities. First up, Zollinger-Ellison syndrome, ZES.
ZES. This is a rare one. It's caused by a gastrin-secreting neuroendocrine tumor called a gastrinoma. These tumors are usually found in the pancreas or the duodenum, the first part of the small intestine. The key mechanism is that this tumor just relentlessly pumps out excess gastrin. Gastrin is a hormone that strongly stimulates the parietal cells in the stomach lining to produce gastric acid. So with way too much gastrin, you get massive overproduction of stomach acid. This leads to multiple, recurrent, often unusually located, and intractable peptic ulcers. They're hard to treat with standard meds because the acid production is just overwhelming.
And these clinicians' notes describe exactly that, a really stubborn case of stomach pain leading to this unexpected diagnosis. Had a patient, terrible stomach pain, chronic diarrhea for months, constant heartburn feeling, pain worse after eating. Put him on standard high-dose PPIs, ulcer meds. Pain kept coming back. Then endoscopy showed even more ulcers, some in weird places like the jejunum further down, refractory to standard treatment. Red flag. Finally did a fasting serum gastrin level test, extremely high, over 1,000, way above normal. That plus a positive secretin stimulation test, where gastrin levels paradoxically rise instead of fall, confirmed Zollinger-Ellison syndrome. Had a gastrinoma churning out gastrin, causing insane stomach acid production, burning holes in his gut. High-dose PPIs are needed for medical management, but finding and surgically resecting the tumor is the goal. Also need to check for MEN1 syndrome, which it can be associated with.
Yeah, the hallmarks of ZES are those stubborn, multiple, often distal ulcers that don't respond well to therapy, sometimes coupled with chronic diarrhea. Driven by that massive acid hypersecretion from the gastrinoma, the extremely high fasting gastrin level is the key diagnostic clue.
Okay, now a congenital issue affecting newborns. Duodenal atresia.
Duodenal atresia. This is a birth defect, a congenital anomaly. It means the duodenum, that first U-shaped part of the small intestine right after the stomach, failed to form a continuous tube during fetal development. There's a complete blockage, usually because the lumen, the passageway, failed to recanalize, to open up, sometimes thought to be due to a vascular accident in utero affecting that specific spot.
And this next story from a new parent shows how quickly this can be recognized after birth. Baby born, thrilled, but after his very first feeding, immediately started vomiting, and it was green, bilious vomiting, very concerning sign. Called the nurse, she looked worried. Noticed his abdomen was kind of flat, scaphoid, not distended, because the blockage was so high up. Took him for an x-ray. Doctor came back looking serious, showed us the x-ray. Classic double bubble sign. 2 big air bubbles, one in the stomach, one in the blocked first part of the duodenum, and crucially, no gas visible further down the bowel. Explained his intestine was blocked right at the start. Duodenal atresia, caused by the failure to recanalize in development. Also likely why I had polyhydramnios, excess amniotic fluid during pregnancy. The baby couldn't swallow and absorb it properly. Needed surgery right away, a duodenodudenostomy to bypass the blockage. Kept him NPO, nothing by mouth, with an NG tube to decompress his stomach until then. They also mentioned it's strongly associated with Down syndrome, so genetic testing was recommended.
That double bubble sign on x-ray is really pathognomonic. That plus the bilious vomiting right after the first feed in a newborn. Almost certainly duodenal atresia. High obstruction, often linked with Down syndrome and polyhydramnios, needs prompt surgical correction.
Okay, a similar issue but with different features. Jejunal or ileal atresia.
Right. These are also congenital blockages further down the small intestine, in the jejunum or ileum. But unlike duodenal atresia, these are typically thought to be caused by a vascular accident in utero, like an occlusion of a branch of the mesenteric artery supplying that segment of bowel. The affected segment loses blood supply, becomes ischemic, dies, necrosis, and then gets resorbed. This leaves a gap or disconnected blind ends in the intestine, creating the blockage.
And this next story, also from a new parent, involves a similar problem but presents differently. Our baby looked healthy at birth, but by day 2, her belly started getting really swollen, distended. Then she started vomiting green fluid, bilious again, alarming. Also hadn't had a single bowel movement since birth. No meconium passed. Doctors did an x-ray. It showed multiple, massively swollen loops of intestine filled with air, looked like balloons with air fluid levels visible, but nothing in the lower bowel, no gas in the colon. Explained part of her small intestine, the jejunum, hadn't formed correctly. Due to a blood supply problem before birth, a vascular accident causing the blockage, jejunal atresia. Unlike duodenal atresia with just 2 bubbles, here we saw multiple dilated loops. And the significant abdominal distension was a key feature because the blockage was lower down. Meant she needed surgery to resect the atretic segment and reconnect the healthy bowel ends. And importantly, this type isn't typically associated with Down syndrome.
Exactly. The differentiating factors are key. Jejunal atresia usually presents maybe a day or so later than duodenal. The hallmark is significant abdominal distension and an X-ray showing multiple dilated loops with air fluid levels and absent distal gas. Reflects a lower obstruction caused by that vascular event, and usually no Down syndrome link.
Okay, let's consider superior mesenteric artery syndrome, SMA syndrome.
SMA syndrome. This is a rarer condition, more acquired than congenital usually. It happens when the third part of the duodenum gets compressed between 2 major blood vessels, the superior mesenteric artery, SMA, and the aorta. Normally, there's a nice fat pad and connective tissue in the mesentery between these 2 vessels, keeping them separated at a good angle. But if that fat pad is lost, often due to rapid, significant weight loss, or sometimes prolonged bed rest or spinal surgery deformities, the angle between the SMA and aorta narrows. This narrowing literally pinches the duodenum shut, causing an obstruction.
And here's a really unique story revealing how something like significant weight loss can have these unexpected mechanical consequences. After losing a lot of weight quickly from an illness, I started having constant stomach pain, especially right after eating. Postprandial pain, often vomited greenish bilious fluid, felt like food just couldn't get past a certain point. Symptoms of a high intestinal obstruction. But the really weird part, it was much, much worse when I lay flat on my back. Excruciating pain then. But if I flipped onto my stomach or curled up in a knee to chest position, it actually got a bit better. Positional relief. Doctors eventually figured it out with imaging. My third part of the duodenum was getting squeezed between the SMA and the aorta because I'd lost so much of that protective mesenteric fat pad, called it superior mesenteric artery syndrome. Bizarre, painful consequence of losing too much weight too fast. Started me on conservative treatment, frequent, small, high-calorie meals to try and rebuild that fat pad, positional changes after eating. Surgery is an option if that fails.
Yeah, SMA syndrome is a fascinating example of anatomical compression due to altered body habitus. The key clues are that postprandial pain, bilious vomiting, history of significant weight loss, and crucially that positional nature of the symptoms worse supine, better prone, or knee chest. That directly reflects the changing angle between the vessels, easing the pinch.
Okay, our final story for today is on achalasia, a swallowing disorder.
Achalasia. This is a primary motility disorder of the esophagus. 2 main things go wrong. 1, the lower esophageal sphincter, the LES, that muscular valve at the bottom of the esophagus, fails to relax properly when you swallow. It stays too tight. 2, the main body of the esophagus loses its normal coordinated muscle contractions called peristalsis, which are needed to push food down. The underlying cause is the degeneration or loss of inhibitory ganglion cells within the esophageal wall's nerve network, specifically the myenteric Auerbach's plexus. Without these inhibitory nerves telling the LES to relax and coordinating peristalsis, food and liquid just get stuck and accumulate in the esophagus.
And this listener describes years of worsening difficulty swallowing, finally leading to the diagnosis. Started subtly, feeling like food would get stuck sometimes in my throat or maybe lower down in my chest. But over the last year, it got much worse. Now, both solid food and even liquids feel like they just sit there, won't go down easily, making me lose weight. That dysphagia to both solids and liquids was a key feature, the doctor said. Classic for achalasia, helps distinguish it from other things. I've even coughed up undigested food hours later, sometimes woken up choking at night. Terrifying. Regurgitation. Doctor did a barium swallow x-ray test, showed me the picture. Esophagus looked dilated like a big sack, and the very bottom part was squeezed shut, tapering down like a bird's beak. Explain the nerves in my esophagus. Those ganglion cells in the myenteric plexus weren't working right, so the LES wouldn't open properly, and the esophageal muscle couldn't push food down. Did esophageal manometry next measure the pressures? confirmed it. High LES pressure, incomplete relaxation with swallowing, and totally absent peristalsis in the esophageal body. Manometry is the gold standard test, she said. Definitive solution. Likely surgery, a Hellermyotomy to cut the LES muscle. Or maybe a newer endoscopic procedure called POM.
That story captures achalasia perfectly. Progressive dysphagia to both solids and liquids is key. The regurgitation, the weight loss, and that characteristic bird's beak on barium swallow with proximal dilation. And the root cause is that loss of inhibitory ganglion cells, leading to the LES failing to relax and loss of peristalsis. Manometry confirms it definitively. It's a true failure of esophageal motility. #outro.
Wow. What a journey through some incredibly complex and really impactful conditions today, from the electrical misfires in the heart to the delicate balance of hormones, the intricate plumbing of the digestive system. It's just so clear how interconnected our bodies are and how sometimes a single breakdown point can cascade into such profound effects.
Indeed, it really is fascinating. And I think what stands out is how understanding the underlying mechanism, how it actually works, really does unlock the whole clinical picture. It connects the symptoms you see, the diagnostic tests that make sense, and ultimately the best path for management. It helps build that narrative around the science, right? Makes it stick. Those patient stories really bring the mechanisms to life.
Absolutely. So what does this all mean for you, our listener? Maybe it's a reminder of the body's incredible resilience, but also, its surprising fragilities. Or perhaps it's an invitation to consider how a single seemingly small cellular misstep or a tiny structural change can cascade into a life-altering condition. It certainly reinforces the power of, early detection and the remarkable advancements in medical science that allow us to understand and treat these things.
And maybe it raises an interesting question to think about. When you encounter new information, especially about health, do you find yourself focusing more on just the list of symptoms? Or do you try to dig a bit deeper to understand the root cause, the mechanism behind it all? And how does that approach maybe change your understanding, or perhaps even your ability to remember what really matters?
That's a great question to mull over. Thank you so much for joining us on this deep dive into these fascinating and really vital clinical cases. We really hope this exploration has given you a clearer, maybe more memorable understanding of these conditions. Until next time, keep digging deeper.